Hi, my name is Linda Tillio. I've worked in the primary care clinic at the White River Junction VA Medical Center for the past 10 years. My capstone project is the result of findings that I made during my research and evidence-based practice class last semester. I was researching a portion of the nurse-led triage protocol from a urology clinic to determine if the recommendation that antibiotics be prescribed for symptomatic UTIs is supported by current evidence. The prescribing practice was supported by my literature review, but a different common theme was emerging. One article after another said that if an adult female is triaged and suspected to have an uncomplicated UTI, which we will dive into in just a couple minutes, there is no need for any diagnostic labs. Diagnosis can be made based on self-reported symptoms. This prompted me to take a look at our outpatient UTI protocol, and I learned that it does not follow current evidence-based practice. The problem with our protocol is that it is too broad and it does not allow for any triage based on gender or symptoms. The way it is written, all patients with symptoms suggestive of a UTI should have both a UA and a CNS ordered, and this practice simply is not supported by the current evidence. The current outpatient protocol is written to provide guidance to registered nurses and licensed practical nurses on when to order UA and CNS to assist in diagnosing UTIs, and it is applicable in the White River Junction VA and its associated CBOCs. A CBOC is a community-based outpatient clinic that is located in a remote area, providing better access to medical care for our patients when traveling to White River Junction is not practical due to distance. Our CBOCs are located in Burlington, Bennington, Brattleboro, Keene, Littleton, Newport, and Rutland. Both men and women's health care is offered at all facilities. As of March 1st, we have a collective total of 21,096 patients, of which 1,491 are women. Per the protocol, nurses should order both labs when a patient presents by phone or in clinic with any of the following symptoms: burning, frequency, new onset difficulty urinating, hematuria, flank pain, suprapubic pain, or foul-smelling urine. According to UpToDate, the key in determining if labs need to be ordered lies in triaging the patient to determine if the UTI is complicated or uncomplicated. The symptoms of an uncomplicated UTI in a non-pregnant adult female include being afebrile below 99.9, having dysuria, frequency, urgency, suprapubic pain, absence of vaginal discharge, and there is no suspicion that the infection extends beyond the bladder. There is no need to order diagnostic labs for this patient. Diagnosis can be made based on the patient's self-reported symptoms. For a complicated UTI, in addition to the symptoms listed on the previous slide, if any of the following symptoms are present: fever above 99.9, other symptoms of systemic illness, flank pain, costovertebral angle tenderness, or suspicion that the UTI is above the bladder, or if the patient has a relapse or recurrent infections, the infection should be considered complicated, and it is appropriate to order a UA and a CNS for this patient. According to an evidence review published in JAMA in 2014, if two or more of the uncomplicated UTI symptoms are present in the absence of additional symptoms from the complicated list, you can predict with greater than 90% probability that she has an uncomplicated UTI. UpToDate suggests that the likelihood that the uncomplicated UTI is caused by the E. coli pathogen is between 75 and 95%. E. coli are frequently found in stool. Females that are a high risk for this particular infection based on the female anatomy. The patient's diagnosis can be made based on self-reported symptoms via a nurse triage. With no labs needed and no need for a face-to-face encounter, patients can be treated safely and efficiently without ever leaving their home except to go to a local or to the VA pharmacy. The exact medication that the prescriber orders to treat the infection can be guided by the local antibiogram, which determines the best medication based on microbial resistance patterns. Women can expect a positive response to treatment within 48 to 72 hours. If there is no symptom relief, she needs a culture and sensitivity so that the true pathogen can be identified and medications can be adjusted accordingly. Providers should not treat asymptomatic UTIs. Sometimes discovering the presence of bacteria in urine are incidental findings as a result of lab orders in an ER, for example, as part of another workup. This patient may be colonized, and treatment with antibiotic leads to increasing microbial resistance and potential difficulty treating symptomatic UTIs in the future. So what do the women's health providers think about the importance that a UA and a CNS play in diagnosing a UTI? A survey was sent via SurveyMonkey to 20 women's health providers at the White River Junction VA and the CBOX, and 9 surveys were returned. The survey participants were asked the following. An adult female calls the clinic with symptoms suggestive of an uncomplicated urinary tract infection. She is not able to come to clinic for evaluation or to leave a urine sample. Will you order her the appropriate antibiotic anyway? In the pie chart, you can see that 78% of providers would be willing to prescribe antibiotics to this patient. Interestingly, the same survey participants were asked if this patient was able to provide a urine sample, would they order both the UA and CNS? And 67% of the providers indicated that they would rather have labs versus prescribing based on symptoms alone. The 2017 survey published in JAMA and a systematic review and meta-analysis published in the 2018 BMJ reported that U.S. physicians feel that overall about 25% of lab orders are unnecessary, and the vast majority do it because they fear litigation. So providers are frequently practicing defensive medicine. Another common reason is not being able to keep up to date on the rapidly changing evidence-based recommendations. A survey was sent to 29 nurses in primary care at the White River Junction VA and the CBOX. 14 of these surveys were returned. 2 of the 29 nurses work exclusively in the women's clinic, and I don't know if they completed the survey or not. They were asked the following. An adult female calls the clinic with symptoms suggestive of an uncomplicated UTI and wants to see a provider. What percentage of the time do you think you should order both a UA and a CNS before the provider sees the patient? The survey indicates that 86% of the nurses believe that they should order both a UA and a CNS to assist in the diagnosis process. This may be because they're following the protocol. They might truly believe that the practice is evidence-based or some combination of both. Our lab services are contracted with equipment manufacturers using a basic cost per reportable for each lab test performed. It is called a cost per test contract, and it includes the equipment itself, reagents, calibrators, control materials, disposables, and a training and a standard service agreement. It is a win-win situation because there is no heavy outlay of cash to purchase equipment, and we're always able to trade up to the newest equipment every 5 years because we lease and we don't purchase anything. When a UA is ordered, it is run through an automated dipstick test. If there is anything of interest, including leukocytes, nitrites, blood, or protein, it is reflexed and examined under a microscope for further evaluation. If none of those are present, the microscope exam does not occur and the UA is complete. If a CNS is ordered, regardless of the UA results, the sample placed in a growth medium in a petri dish is incubated to grow and then to ID the bacteria, and then we can determine the antibiotic sensitivity. Right now, these are 2 separate independent orders and are frequently ordered at the same time. I worked with the lab manager to obtain cost per order in an attempt to put a dollar figure on the cost of potentially unnecessary labs. During the month of October 2017, there were 22 urinalysis ordered, 14 were placed under a scope for additional study, and 18 had simultaneous culture and sensitivities ordered. These are strictly the number of labs that are ordered, and they do not reflect any results. The cost of a UA per contract with the addition of the VA lab personnel is $4.33 per unit. The reflex microscope exam cost was difficult to analyze by the lab as there are many variables that can occur which affect the cost. For example, the necessary level of skill of the lab tech, the time involved, and any additional materials. A rough estimate was $7.10. The cost of the CNS per contract, including lab personnel, was estimated at $30 per order. The results of a systematic review and a meta-analysis published in February 2018 in the BMJ found that between 55 and 77% of all UA and CNS orders in the primary care setting in the United States are not clinically indicated. The overuse of tests when the potential for harm outweighs the benefit can subject the patient to harmful treatment. For example, prescribing antibiotic to an asymptomatic patient with labs suggestive of a UTI can result in C. diff. Several of the research articles that I reviewed reported results from internal cost reduction strategies, and all were successful in reducing costs when internal stops were placed in the system to prevent overordering of unnecessary labs. For example, a 2011 QI initiative in the Syracuse VA showed a reduction in lab costs simply by implementing a utilization software. A popular financial model for healthcare facilities in the United States is fee-for-service. Medical services are unbundled and they're paid for separately. This model provides incentives for ordering tests, treatments, and procedures as income is based on the services that are provided. In this model, labs equal income. But the VA is funded through the capitation system. Capitation financing is a prospective payment system that pays a fixed amount per enrollee for a defined set of time for a defined set of health services, regardless of the services that are used. In a government-funded hospital, labs are an expense, and it is important that they not be ordered frivolously when they are unwarranted. Not only do we owe it to our patients to be current on evidence-based recommendations, but we need to be good stewards of our tax dollars. There may be some financial reimbursement for women with outside insurances, and I was not able to obtain data on that. An opportunity cost is the value of something that must be forfeited in order to achieve something else. Because every resource can be used in an alternate way, every decision has an associated opportunity cost. By ordering unnecessary labs, there are associated opportunity costs as follows. It is poor use of the lab resources, and the lab equipment and staff are spending time collecting and processing specimens that don't need to be done. Resources could be otherwise utilized for clinically indicated labs. Providers and nurses don't need to be spending time ordering and following up on unneeded labs. There are plenty of other demands on their time. Scheduling appointment for patients that don't need to be seen reduces access to clinic for patients that truly do need a face-to-face evaluation. Maybe most importantly, the patients save time. They don't have to miss work by not having to come to clinic for unnecessary labs and potential face-to-face visits. So for my next steps, I need to meet with the Evidence-Based Practice Committee to present my findings. Next, I need to develop a nurse triage protocol to separate complicated from uncomplicated urinary tract infections. I would then like to educate the nurses and providers about current lab recommendations. If a change in the protocol and nurse provider education is not effective in reducing the numbers of labs ordered, we could consider adjusting the lab ordering process itself. It might make sense to have a reflexed UA and CNS order. In other words, if a UA is negative, don't do the CNS unless there are extenuating circumstances. And finally, to measure the results of the effect of changing the protocol, further lab data should be obtained looking at the additional months prior to the protocol changed, and then be compared with several months of data after the initiation of the new protocol to see if the number of UA and CNS orders has declined.